Okay, chronic pain. Well, boy, this is bad news for lots of reasons. The World Health Organization, looking cross-culturally, determines that ultimately between 15 and 20% of people will develop some form of significant chronic pain. So it's very widespread. And just a little bit of the biology here is that when people feel something from their muscles or joints or what have you, there are separate pathways that go into the spinal cord and then up the spinal cord. And one of those is our nerves that only detect temperature changes, okay, heat or cold. One of them detects vibration, which is interesting. Only vibration. One of them detects pain, okay, and gosh, I'm forgetting the last one. Vibration. Geez, I can't believe I can't remember that. Oh, maybe it'll come to me. But you have these different nerves that are delivering different messages. They're all going up into the spinal cord. Now, what happens is that here we have nerves entering through what they call the dorsal horn. It's the back part of the spinal cord, and it enters here, and then it travels up the spinal cord, as you might imagine, and goes into the brain. Now, one thing I want to say here is that at this level, outside the spinal cord, it's called the dorsal ganglion grouping of nerve cells. But at this level, endorphins can work to dampen the intensity of pain actually going into the spinal cord. And people with chronic pain are often treated with antidepressants, even if they're not depressed. The antidepressants that increase serotonin and norepinephrine work. The ones that just increase serotonin, like Prozac, does not work. Those that just increase norepinephrine do not work. But those that they're called the SNRI, selective serotonin norepinephrine reuptake inhibitors. And what they do then is they may have some effects in the brain, but their main effect is out here at the level of the spinal cord. And these neurotransmitters, when they're found in larger amounts, then work hand in hand with endorphins to block more pain coming into the spinal cord. Excuse me just a minute. The reason I have a dry mouth is because I'm taking nortriptyline, which is one of these antidepressants that does this. It's a tricyclic. It has dry mouth as a side effect, unfortunately. But I have a cyst in my spine, and it's resulted in really a huge amount of pain. And this is very helpful for me. So a lot of people who have chronic pain may be recommended that they take an antidepressant. Now, one of the downsides of this is that because everybody has internet access, they get on the internet and they put nortriptyline or Elavil or something in there. It's like, oh, it's an antidepressant. Oh, this guy must think I'm crazy or depressed or something. Now, rates of depression are quite high in people who have chronic pain, but there are people that aren't depressed, or the stigma of depression is a significant issue, and then they think, oh, this is an antidepressant. What this doctor thinks I'm depressed or what have you. But that's not the action here. This was not FDA approved, the tricyclics, but we move up recent times, and the antidepressant Cymbalta now is FDA approved for treating depression and treating pain, and it works in a similar way to some of these tricyclic antidepressants. Okay, touch, vibration, temperature, and pain. There we go. I was missing one of those. Now, here's one of the problems. And this is a theory called central sensitization. And this is something that can develop over a period of time and can result in a significant increase in chronic pain. Let's take a look at this. Keep in mind that you've got these 4 different types of nerves coming into the spinal cord, okay, and then headed up to the brain. With chronic pain, one thing that happens is at some point, and it's judged to be somewhere between 3 and 6 months, that this really is substantial, you start getting increases in BDNF. And we've been talking throughout this entire course about BDNF being so incredibly helpful and important up in the brain, and that's certainly true. But remember that BDNF is nerve growth factor as well. And what it does is it starts having an effect on the incoming nerves, and it causes dendrites to sprout. And what happens then is, if you take a look here, the pathway for touch, just for touch, it's referred to as lemniscus 4. The one for pain is lemniscus 2. They're next to each other, and they start infiltrating each other with dendrites. And beyond a certain point, now touch produces pain. So the person who, for instance, maybe they had a really severe shoulder separation or something, but it's healed. But it took a long time. They had complications, and they had a lot of pain. And they're 3-4 months out, and they're going, I'm in agonizing pain. And the doctor says, well, we did an MRI, and and your range of motion is good. You shouldn't be having any pain now. Okay, so what does that mean? I'm hypochondriac, or I'm into drug-seeking behavior, or what have you. One possibility is that the remodeling then of the spinal cord, and now just touching, which would happen if you roll over in the nighttime. The actual source of the pain initially can be completely back to normal, and yet now you have permanent chronic pain.
It never goes back. No,
it doesn't. There are experimental treatments where they inject drugs that can block BDNF. Okay, very experimental. Okay, but the main thing is to get in and aggressively treat pain, and that oftentimes is not done. Okay. In addition, there's another piece of the central sensitization hypothesis is this. Take a look here. We have these different sensory systems sending up information into the brain, okay, and pain, touch, and vibration and temperature. It goes to part of the brain stem, and then it goes up, and part of it goes to a part of the cortex that is a sensory area for that. So I got terrible pain in my thumb for whatever reason. Well, you go up into the brain, contralateral representation is my right thumb, go over in the left hemisphere, the thumb area, my sensory strip is getting pain signals there, okay? But that's not all. It feeds into the amygdala, which has probably, this is a theory, a lot to do with the experience of pain, the emotional experience of pain. There are some people that tolerate pain, and not just by gritting their teeth. They have a better capacity to kind of block pain than others do. And look, it comes up here to the cingulate gyrus. Now, I got to tell you, it's a really interesting story. I can't remember this guy's name, but this was like 30 years ago when I first moved to Sacramento. There was a psychologist at UC Davis. He worked in the Department of Anesthesiology, and this guy, for people that were allergic to or intolerant of general anesthetics, with some people who were hypnotizable, he would hypnotize them, and then they'd undergo like abdominal surgery and not feel any pain. And just like, whoa, what in the heck is that all about? That's just crazy. It's crazy good. And when states of focused concentration that you get with hypnosis, but also with meditation. You probably have heard stories about, these Hindu monks who practices deep kind of meditation, and they can walk on nails and all that kind of stuff. Certain kinds of experience of hypnosis, meditation is another one, have a change in the brain, and probably it's happening at the level of the anterior cingulate. Okay. And so one part of this theory is not just what's happening in the spinal cord, but it could be there's something happening up in the brain where there's a failure of top-down control. So under normal circumstances, we dampen pain a little bit, but you hypnotize these people and they shut it off completely. But some people may have a failure of top-down control, and these are people that are more likely then to experience enormous amounts of pain when maybe other people don't have as great a sensitivity. This slide actually, for future reference, is just what I was talking about the use of certain antidepressants that activate the increased levels of serotonin and norepinephrine. Okay. And here are the drugs. These are the tricyclics on top and the newer drugs down on the bottom that share that property. The other thing that's interesting too, and it's a part of the picture, it's becoming increasingly clear with depression, there are changes in the immune system. And what I know that you all, in reading the book by Sapolsky, has a whole chapter on the immune system, so let me just do this briefly. But with depression, some white blood cells they secrete their own kinds of messenger molecules. We talked about them earlier, that's called cytokines. And some of the white blood cells during chronic pain secrete excessive amounts of pro-inflammatory cytokines. And having inflammation is very important for dealing with, for instance, you have a bacterial infection in your knee or something, and inflammation around that area is a part of what helps to heal that. However, chronic activation of the immune system and walking around all the time with high levels of these pro-inflammatory cytokines can cause a lot of generalized aches and pains. Lots of people with depression, they have kind of ill-defined pain. Headaches are very common, joint pain and muscle pain. And the interesting thing about this is the antidepressants actually shut down this excessive amount of inflammation. And so that's one reason that people physically feel better oftentimes when they are treated by antidepressants. Okay. Now, this is kind of the bottom line here, and this is the current thinking, is the critical window is 30 to 100 days. So we're looking at a month to 3 months. Now, that doesn't mean that the window shuts and you can't do anything about it, but there's more likelihood that after 3 months, or sometimes a little bit less, some of these changes are happening in the spinal cord that can lead to chronic pain. So what you have to do then is you've got to get in and aggressively treat the pain. And here's the recommendation. This comes from the American Society for Pain Education. Disuse may be a factor. When it's judged to be appropriate medically and also oftentimes evaluated by a physical therapist to start moving, for instance, that shoulder, you need to do it. Or to start exercising again. And a lot of times when people have had injuries and surgeries and so forth, the time that they start needing to move, it hurts so much they don't do it. So disuse in itself can aggravate things. Treatment of depression, very important here as well. And then, of course, physical therapy and exercise. And I know, having gone through this chronic pain problem myself, I'm not trying to be critical of my primary care doctor, but the first go-to drug was Vicodin, and it dampens the pain, but narcotic medications have a whole set of their own problems as well. Okay.